Welcome to our third jam session and listening session hosted by Intel. The theme is really thinking about what's cutting edge today and what's the future. We've had prior sessions looking at smart platforms for hospital systems to the future of digital health. Last 2 weeks ago, we did a session on future of robotic and augmented reality enabled surgery and future medical education. And synergistic with all that, the thematic of this, our third jam is really the kind of the connects with the others, but really how care is becoming much more connected, data-driven, everything from connected wearable devices to the virtualization of visits and the using of VR, AR, and extended reality to enable therapeutics as well, as we hear from Brennan and others. So just a quick caveat, mute yourself when you're not on. Edit your name if you can, the affiliation. Use the chat as you hear things or ideas. Use the chat pretty actively to share resources. After we have sort of the opening elements from our lead discussants, we're going to be discussing and jump in and don't be shy. So with that, I'm going to pass it over to Maria from Intel to give a little bit of framing. I think on behalf of Stacy, who's tied up with a minute, a little bit about Intel and their bigger picture here and what's coming next. Over to you.
Thank you so much, Daniel. So good morning, good afternoon, good evening, wherever you may be. On behalf of Intel and Stacy Schulman, who is our Vice President of the Internet of Things Group and GM of our Health and Emerging Technologies. My name is Maria Zorotovich. I lead our customer experience efforts. And again, as Daniel said, we are so pleased for all of you to be able to join us on our third jam of this year. We have one more to go in December, and we hope that you can join us there. For those of you that are new and joining us, just a little bit about why are we doing this. Within health and life science space, obviously, as many of you are practitioners in this space every day, there is so much to be done. And for us as a company in Intel and where we sit from a technology position, we are on a learning path and a listening path. And so it is really important for us to be able to have these opportunities where we can hear from the community, discuss different items and issues, and then begin to collaborate together to figure out how do we remove some of these barriers, or how do we solve these problems, or how do we help deliver new breakthroughs for all of us. And so again, I just want to thank everyone for taking the time for attending today. I look forward to the discussion. So far, they've all been fantastic in terms of points of view. I particularly want to thank all of our lead discussants who have joined us. Thank you so much for coming here and sharing your thought leadership and helping kick us off in this conversation today. Daniel, back to you.
Great, thanks, Maria. And we've also been trying to synthesize the takeaways from these, which we'll be sharing afterwards. I'm Daniel Kraft. I have a few hats: physician scientist. I chair the XPRIZE Pandemic Alliance Task Force, which includes Stacy Schulman, where we met. And I'm really excited to have three friends and lead thought leader discussants who I'll introduce in detail and as they come up. But we have Dr. Leslie Saxon from USC and founded and leads her Center for Body Computing, a lot around connected Internet of Things on the body and beyond. Dr. Brennan Spiegel, also in Los Angeles area, who leads up a lot of research on health services, but a lot of deep detail on VR, AR, and extended reality. I think we'll focus on VR today. And Stefano Beanie, rockstar orthopedic surgeon at UCSF, who's highly intertwined in the technology and nurse space of orthopedics and digital and connected care. So I'll introduce those folks in more detail as they come up. This is a jam. The idea is not just to be a straight presentation, but after we have short but 10, 15-minute presentations from our lead discussants, the idea is to then have an intermingled discussion. We have some amazing folks joining, from Dr. Dave Albert, the founder of AliveCore, to Shauna Butler from many realms, CU Now and beyond, to kind of add to the color. So everybody jump in. It's a learning experience and a collaborative jam element. So our hosts are Intel. I was lucky to actually give a talk there a couple of years ago. My joke is we've had Intel inside, but I got to be inside Intel. And this is a chance for us as well to sort of help Intel see what's coming into this future and what kind of technology stacks might they want to be building to enable our future of more connected, mobile, and virtualized care, not just for what's possible today, but what's coming into the future. And that future has been highlighted by the challenges of the pandemic. Many fields are in the fourth industrial age. Health is often stuck in a bit of the third. And COVID has been a bit of a catalyst for especially all things virtual and connected care, from clinical trials to hospital at home. And we tended to think about healthcare in the frameworks of the four walls of a clinical space, but clearly our age is moving from hospital to home, or hospital to hospital, and more virtualized care, as we'll discuss. It's giving us the opportunity to break open some of the silos of how we define care and how it's been practiced for eons, maybe even outside of the bucket of usual body parts, now that we're in our extended genomic and multi-omic age. We certainly are hoping to shift from our sick care model of intermittent data that's very episodic, only usually occurring when folks visit the clinic or ER or ICU, which leads to a reactive usual mindset where we tend to wait for the patients to show up with a problem of a heart attack, a stroke, a late stage cancer, to one that's much more continuous with the things we'll talk about today, whether it's wearables or connected smart homes or using your VR headsets. So much more continuous data interaction that's much more personalized, proactive, and as thematically can start to bring care virtually anywhere, anytime, arguably with better costs and lower outcomes. And of course, a lot of that is riding Moore's law, which comes from Gordon Moore, one of the founders of Intel. We want to be thinking exponentially, not just about the chipsets of today, but what's going to be possibly next. And now that's been digitizing our care. It's clearly created this Internet of Medical Things, which often creates terabytes of data. The challenge is often moving from data to actionable insights that can be used at the bedside, at the website, and often don't take the traditional 10 to 15 years or more to translate to what's actually spot on care that's truly personalized and relevant. And of course, a lot of the incentives are shifting to bring care from hospital to home to phone to on and inside our bodies. A lot of that is in this realm of connected mobile digital health. And a lot of that is powered, as you will talk about, from our new era of wearables. I'm wearing 3 or 4 right now. And it's interesting to see how they've been shifting from consumer to medical. Dr. Dave Albert's on the call. He might describe later what's up with AliveCore, which is not exactly, well, a wearable on the watch at some point, but also the ability to collect clinical grade EKGs and beyond. And so these sensors are evolving. I'm wearing a little patch I found it a month or 2 ago called BioIntelliSense. There are other patches, but this one lasts for a month and correlates a lot of data. So the ability to have hospital grade data that's worn for a month, I think, is getting unique. And then software and analytics on a service on top of that. So big picture, we're hopefully moving from this era of quantified self to quantified health, where our digital biomarkers are going to flow, whether it's our connected blood pressure from a watch band or patch as opposed to the blood pressure cuff, so that our digital biomarkers can be used for optimizing prevention health, doing earlier diagnostics or more personalized therapy. And the data is coming from all sorts of sources. Our cameras can pick up our vital signs now. Our voice can be a biomarker. And again, the challenge from the clinical side is how do we synthesize that? None of us wants more data. We want the actionable information that can be used in a proactive way and provide sort of the synthesis of all that information so it can be used continuously and more proactively. And as we'll hear from Brennan, a lot of things happening at the convergence of, AR, VR, XR. I've got my Oculus Quest here, which is great for gaming, but is also being used for therapeutics, medical education, as we talked about on the last call, and being able to sort of visualize all the data that's coming together. So I'll leave it with that as an opening thought. I think a lot of things we've talked about on these jams and beyond are not about any one tech set, but a lot of them are this convergence of Internet of Things, new forms of data, new forms of feedback, new forms of collaboration, and that we can sort of use that mindset on the Moore's Law path to help create a brighter future for all of us across healthcare. So with that, I'm going to hand it over to our first lead discussant, Dr. Leslie Saxon. I was lucky to meet, I think, 10 years ago when I went to one of the earlier body computing conferences. I think it was my first keynotes. And to see some of the technologies that have evolved and folks who've been there, I think I met the Whoop company there 6-7 years ago. They're now a $2 billion plus connected play for the sports arena. And Dr. Saxon is also connected to the realm of not just health, but also augmenting our performance, whether you're a soldier or an athlete. So I'm going to hand it over to Dr. Saxon to tell a bit about what she's up to and what she sees coming next in the world of body computing and beyond. Dr. Saxon.
Thank you, Dan. I'm Leslie Saxon from University of Southern California, and I run a center called the Center for Body Computing that is 15 years old. So better lucky than good, because at the beginning of this thing, as Dan mentioned, it was more science fiction than fact. This idea that we'd have a connected healthcare system that was able to collect data off a person all the time in a continuous model of care. And Dan, by the way, you did an amazing job at that keynote. And I thought it was fantastic. It was one of the better ones we had, because you're a great futurist. But the idea then and the idea now is that the customer for medical care, or what we call life care, is the individual. And so healthcare products, life care products, need to understand that the end user is the customer and designed for that person. Because really, to me, the most profound aspect of all this is that we can finally leverage a patient or a person in their own health or their own sickness. And so what that means is abandoning this model of care where we communicate with patients in a language they don't really understand, but we understand, and even other specialists don't understand, that patients are seen intermittently and largely kept in the dark in a kind of paternalistic model. And so we sort of leave a lot of talent on the table. And I think that the promise of a digital healthcare model that's a more continuous model that doesn't differentiate between your health and disease so much, but just surrounds you in the same way that other digital services will do, is really exciting. And so that means that we can create this generation of health literacy. It also puts a little more expectation on the individual receiving those services, right? In the same way that you have to curate and your services and decide what you want to share and other things in the same way other digital models do. So what I see happening now that was accelerated by the pandemic is that both the larger clinical community, the traditional clinical care community, as well as the patient community, if you will, in traditional care now sees that doctor and patient in the same room has sort of been liberated and they can receive care over a screen. And then there's this amazing sort of harmonization of diagnostic products that can sometimes be therapeutic products as well. So commercial and regulated, FDA cleared or FDA approved software and hardware that can diagnose patients. So that can be anywhere from a COVID test to a blood sugar, right, to an EKG, to a notification that you have an arrhythmia or something else, to now a censored knee implant. So orthopedic surgeons don't have to be in the dark when a patient complains that they don't have an optimal result from their knee prosthesis. That's a really exciting thing. The other thing I would caution people about is that our center does the research to show that these solutions are meaningful and improve outcomes and are safe. And from a software or a hardware perspective, a lot of this data no one's seen before, even experts, when it's streaming continuously. And I have studies where I'm continuously streaming data from professional athletes, elite war fighters in operational training and other environments, and patients, even heart patients. I'm getting all this data that I've never seen before. So we don't have normative values. We don't know what it means. So you kind of have to sit on it for a while and understand it in the context of other things. The other great opportunity, and Dan talked about silos in medicine, but it's really about the human being. I mean, as an interventional cardiologist for years, I was just so self-congratulatory about my little piece of implanting a device or doing something else. And I was rewarded because I made money for the institution because I implanted these expensive devices. But was I treating the whole patient? Was I leveraging all the things that connected device could do? Did I care about the depression of the patient with heart failure, or their confusion about their diet or activity, or cost of their drugs, or medication adherence? No, I paid absolutely no attention to that, and I wasn't rewarded to. In fact, I was penalized for doing that. So, because that meant I was spending less time doing the things that generated income. And so I would tell you that what we're doing now, and what this toolkit of digital and connected care allows us to do, is to allow people to assess themselves, because remember, the customer is the end user. So how is your mind and body doing? What is the relationship between your mind and body? How can I give you a user experience where you know you're going to get sick or at risk, and you can mitigate that, so we can do all the amazing things that medicine and traditional care did in the last 100 years, right? We increased longevity. We have better outcomes for cancer. We have amazing operations for trauma and for cardiac disease. So how do we do that for the mind body now in the future? How do we say to someone, you know, you're degrading in this way and that way, either socially or behaviorally or cognitively, and let's make you aware of the factors that influence that degradation so you can help mitigate them, and we can work with you to optimize yourself and to move that degradation, you know, out to the right. I think that's enormously an important opportunity. And we don't build or test anything these days that doesn't measure mind and body. I've had an incredibly humbling experience in learning that through the digital health research. And I think it's probably one of the most important things we now do in our research. So the second thing, of course, is ethical use of data. So we could say that Internet 1.0 was this amazing thing, right? Ruthless efficiency, and it grew in the wild and great things happened. And who knew there'd be cloud and everything else. 2.0, maybe not so good. Maybe a lot of exploitation of users from Google and everybody else in advert. 3.0, if it includes healthcare, better not be 2.0, or we will really mess people up, particularly with all the problems we're having with cybersecurity intrusions and ransomware and everything else. So 3.0 has to be pretty thoughtful, pretty ethical, has to have some kind of document that talks about preserving the human autonomy, like the World Health Organization has talked about with data, machine learning, or AI. So another great challenge is understanding and protecting data. And it's well beyond HIPAA. It's really everything coming off a human, how to connect it together, how to store it, secure it, and how to protect it from exploits of many different kinds. I think there's going to be important legislation. There are a number of bills right now that are going to address this. And it's, you know, part of the executive order and cybersecurity. So it's impacting healthcare. I'm in conversations with the Department of Homeland Security at HHS and everybody about sort of this evolving field. So while a lot of wealth was created, obviously, from technology companies, we really have to now sort of understand how to constrain some of this so that we can protect people as it relates to their health, right, and human performance. So I spend a lot of my time in that area now, probably 30-40%, because you can't talk out of both sides of your mouth. You can't talk about how you're developing a scalable healthcare system that's going to take people from infancy to their chronic disease and measure them and optimize them at all times and not pay attention to the security privacy issues, right? So that's almost like, you know, the kind of global warming part of this whole thing that I try to be honest about. The other is that research is a critical part of this. So you can put up programs and you can put up products, but until you show that they're safe and effective at scale, you're really, I think, not doing the right thing. So the importance of new companies, particularly, is investing, getting enough in capitalization to actually do the research to show their products work. And I'm a firm believer in that. And it's not appropriate to blame the FDA anymore, because the FDA has structures that can help define how to show your product has done that. Dave Albert and AliveCore has been on a journey doing that for a long time, and it's been very important, I think. So Dan, that's probably enough for me. But those are sort of things I'm thinking about and think will be important for the future.
Thanks, Leslie. When you mentioned, you know, you've been an early adopter and instigator and creator of the ability to collect this data remotely. As I briefly mentioned, you know, clinicians don't want the data, they want the insights. How do you see that integrating into the workflow, whether you're doing that USC or Keck, to make sense of the terabytes of data?
Yeah.
And align that with the incentives for clinicians to use it. It could be the mind-body piece, but unless they have a way to, you know, get reimbursed for tracking someone's cognitive state. Yeah.
It's a great question. It's an important one. So what I try to say to the clinical community, and I believe the care provider community, is that this new model of healthcare will be enormously liberating for us and allow us to really leverage the talent pool of care providers. Because at the end of the day, traditional medical centers really don't want to have a huge ambulatory practice. They want to do acute care things. Providers, the sort of quality of life of a provider these days in the American healthcare system is really poor, because we're completely burdened with compliance obligations. The EMR is the worst piece of software maybe I've ever seen. And it's all about generating the bill. And it's never about maintaining the quality of the doctor-provider-patient relationship and really understanding and diving into the issues that confront the people that need us the most. It's a lot about seeing people who maybe don't need to access us. There's a lot of cost and waste. So I see these solutions as liberating the care provider and the patient with a lot of efficiency and a lot of data that will direct us toward the appropriateness of the time we spend with someone versus allowing an algorithm or something else to manage that patient, with the security, with the umbrella of care, still feeling that umbrella of care to what people say practice at the top of our license. I think that will ultimately make more money for medical centers, allow them to access a talent pool well beyond themselves. So the USC brand umbrella isn't just maybe 5-10 million capitated lives, right? It's a global a community where we're leveraging our experts globally, and we're creating a totally different type of brand and partnerships, et cetera. So that requires planning and investment, and healthcare, acute and chronic healthcare is so hard that many medical centers haven't, just providing that, and their margins are slim and everything else. They're always playing catch up. So just having the time to think about that and plan that is very tough. But I think that's where would and should evolve. And the United States could kind of rule the world in that way if we put our mind to it. I'm very fascinated, Dan, why companies that have trillions of valuation like Apple or Google never really have started the medical school or the hospital. And I think it has a lot to do with culture, in the same way that medical centers culturally are having a hard time to carve out the time to really think about the future of care and connected care as it relates to their identity. Companies that could afford to do this aren't doing it because they think they make devices or something else. They really don't have the culture to change the world in that way, even though they've transformed the world in other ways, right? I just think it's kind of fascinating because I think about and I know you think about this a lot, who's going to do it, right? Who's going to do it? So probably ideally it would be a collaboration. How it will play out, God only knows,
Yeah, there are new medical schools even in LA, the new Kaiser one. We'll see. We talked a bit on the last session about the future of education. Part of that, just the last code, and this will transition to Brennan Spiegel, is you've been a kind of pioneer of, we talk about virtual care and talking to a doc on the screen, but you've turned yourself into an avatar. You've got that amazing Center for Creative Technologies there where it can use the same technology for turning avatar actors into avatars. You've been turned into an avatar. What's a brief takeaway on what it's like for maybe this next generation of patients interacting with you virtually when you're not there, and any from that?
What scares me about that a little bit, and I love it, because my virtual human, Leslie, can deliver care for atrial fibrillation or arrhythmias based on voice recognition AI, and that's vetted, standardized, guideline-driven care, and all the cardiologists could do that. So we know that information delivered to patients is appropriate. We know disinformation is a huge problem now, right? Many younger people don't even want to see the virtual me. They just want to text, and they trust that. So what scares me about all that is that people feel absolutely cared for almost in the same way as seeing me. Even older people think it's like age-related, digital, under 25 or over 25. But most people will respond if it can emote to a virtual agent in the same way and provide the same trust to it. So I feel a great responsibility to make sure she's good, and she's always in a good mood and all that stuff, right? So that people almost trust it too much, and they think it can do more than she can do. She talks about cardiac arrhythmia. She can't manage her diabetes very well, and she can't manage her stroke. You need somebody else. So it's kind of scary to me a little bit, so we need to be really cautious in the way we deliver these and their parameters. And she's not an ER either. So there's that, but it's super promising for providing the kind of education that people need. And we spend a lot of time. So even in people who don't have literacy, you can create medical literacy through short form video and other things. I mean, we are creating content that is so amazing to tell people really what they're experiencing and having. And that insight and education that you provide to people, not shutting them out from that, allows them to advance their own care and continue to build the evidence base to make a global healthcare system better and smarter. So again, this leveraging the user, educating the user, and then letting them help guide the care process is so profound. That's one of the big lessons I've had, because I didn't practice medicine that way for 30 years, right? I was the boss, and this is like completely different, and it's better. It's actually better. It's real democratization, as long as it doesn't get messed up.
And I imagine the Dr. Leslie Saxon 5.0 won't just know electrophysiology, but you'll be able to manage the diabetes and mental health. All those avatars are blending. So with that coda, I want to switch over to our next lead discussant, Dr. Brennan Spiegel, who is at Cedars Sinai and is definitely not your average gastroenterologist. Amongst many hats in doing innovation in healthcare, he's really been a thought leader and innovator in the world of AR meets VR meets extended reality for particularly in the therapeutic side of the equation. He has a great book out called VRX. I'll put a link in. Over to Brennan to share some of the great work that you and your colleagues are doing.
Thanks so much, Daniel, and everyone else for inviting me and for being here today. I really enjoyed that last discussion, and I think this is a nice extension of it. Like Dr. Saxon, I'm also an interventionalist by training, gastroenterologist, and of course get paid for doing procedures and stopping people from bleeding. But long ago, I recognized there's a whole lot more to medicine than that, understanding the mind-body connections, understanding consciousness. What is the nature of consciousness? I was a philosophy major, so my mind tends to go in these directions. And that ultimately brought me to virtual reality, which I'll talk about briefly today. But just by way of background, I'm a professor of medicine and public health at Cedars Sinai and at UCLA. I'm also an assistant dean at the medical school, David Geffen School of Medicine. I direct health services research here at Cedars Sinai, also oversee our master's degree program in health delivery science. And in that, I teach the class on digital health science. And thank you, Dave, who is also teaches in that class actually each year now, which is terrific. And I also run our CTSI at Cedars Sinai and UCLA. So I'm going to share some slides because what I'm going to present is very much a visual science. And it would be harder to present some of this without showing you some pictures. So I'm going to start with this. I'm actually going to stop it for a second because I need to share my sound. And let me do that again. This is me with one of our now over 3,000 patients at Cedars Sinai who have used virtual reality in our hospital. And she's allowed us to show this image. And at this particular moment, she's contemplating whether to use virtual reality to help manage her pain. And she's been in the hospital multiple times over the course of the year and has had recurrent pain requiring a number of different medications. And I'll show you in a little bit what happens when she actually used virtual reality. For those of you that know about VR, you can tell this is a rather old picture now, using the old Samsung Gear VR. And now we're using much more modern headsets that I'll talk about in a moment. So of course, when you think about virtual reality, most people think about, teenagers playing first-person shooter games, maybe in their parents' basements or something like that, wasting their time. And it is that. Virtual reality certainly is that. And that sort of concept of VR has only been strengthened with this recent announcement that I think you're all familiar with now. Of course, there's a variety of reasons why Facebook has changed its name when it has, but as probably most of you know, Facebook is now building the metaverse, which is to be determined whether that's something fantastical or horrible. I guess we'll find out in time. But there's over 10,000 programmers in Europe right now crafting this sort of extended reality super universe, and we'll only come to learn in time what that might mean for healthcare. But in healthcare, we've been learning that there's a whole lot more to virtual reality than just gaming and entertainment. And this is, again, a rather old headset, a picture, though, that I really like to show because it demonstrates how emotionally evocative this technology can be. And we've been learning over the last 6 or 7 years now, how do we leverage this to make meaningful and observable changes, measurable changes in the care of patients, not just immediately, but over long periods of time. This young man, when we took this picture, was in severe pain, doubled over from sickle cell anemia in the hospital. But at this moment, he's flying over fjords in Iceland, and you can see kind of the emotional expression on his face. And this is an older woman who has cirrhosis or chronic liver disease, and she's in a great deal of pain. We can't use opioids because it makes her encephalopathy or brain fog even worse. So we're trying to find ways to manage her pain non-pharmacologically. And here she's sitting on a beach in Hawaii, sort of enjoying herself. And again, I'll talk a bit more about how we use it for pain in particular. So of course, the headsets have gotten more and more sophisticated. And this is the headset that we are currently using for most of our research and development, developed by HP. It's considered the most advanced VR headset. And what's really interesting about it is it has onboard biosensors. So we can now measure not just psychometrically how people are doing, but biometrically in real time with eye tracking, pupillometry, heart rate variability, and an integrated construct that HP has validated called cognitive load. And just this week, this is a screenshot literally with my phone. We are now able to monitor on a smartphone, on a computer, however we want, in real time how our patients are doing. And this is me sitting in one of our own virtual reality meditation environments just a couple days ago, where I'm meditating, and then my colleague keeps interrupting me with some sort of discussion points he wants me to note. And every time he does, you can instantly see how my cognitive load changes. I'm moving my eyes around more, my pupils are starting to constrict, my heart rate variability changes slightly. All of that can be seen now, and we can start to understand the sort of physiologic parameters of using virtual reality. Now, I do want to tell a quick story here about one of the first times I used VR, and I traveled out to the University of Barcelona, where Dr. Mel Slater has been studying therapeutic VR and its psychological impacts for decades. And in fact, there's been a whole cadre of scientists kind of quietly understanding the role of VR long before people like me had even heard of virtual reality. And so when I went to his laboratory, he put me in this room. And it's a rather nondescript room with sort of 4 draped walls, a chair, and a coffee table. And he had me sit down in that chair and kick my feet out on the coffee table. And here's his postdoc, Ramon Olivas, who is setting me up with these sort of haptic devices on my wrists and on my ankle. And then he puts me in the headset, and stereoscopically, all of a sudden, that room changes into this sort of beautiful living space. And I'm looking around in these 2 3-dimensional views, reconstructed stereoscopically, and there's a chandelier and there's very nice wood paneling. And I see my legs sitting on that table in front of me. And then they drew some blue lines on the table, and they said, why don't you go ahead and trace those lines out with your foot? And I did. And in one-to-one synchrony, all of a sudden, I was starting to embody this avatar. We talked a little bit about that in the last discussion. And I started to realize, wow, like, whose legs are those? I mean, I'm moving my legs, but those legs are moving at the exact same time. And then what he did is he dropped some balls from the ceiling. And as each ball hit me, I can physically feel it because the haptics were synchronized perfectly. And now I felt like I had completely inhabited this body. Now I'm showing this to you for a reason. I'm showing it to you to describe what happened next, because what happened next is very hard to put into words, but I'll do my best. And I'll show you what happened, but it's really impossible to explain. What happened next is he separated me from me. All of a sudden, I had been splayed apart from my own body, and I started to float up to the ceiling, and these balls followed me. And as I looked down, I could see that I had just vacated this now motionless body, and I was having a complete out-of-body experience. And I'll show it to you again because it's a little hard to even take all this in, but I realized that I had died. And in the process of dying, these balls kept sort of following me, reminding me I was still a being. But in the process of dying, I recognized that the process of dying need not be catastrophic. It can almost be mystical or spiritual or even religious, depending upon your point of view. And so this kind of got me thinking about what is the nature of consciousness. And I've never forgotten this moment. And in fact, it turns out Professor Slater has studied this in a randomized controlled trial. Very interesting methods I won't go into right now, where he has pretty definitively shown that it can reduce fear of death, having gone through the process of dying. And so we're now evaluating this for patients with existential anxiety at the end of life. To be able to practice your own death is a fantastical use and an ethically interesting use, by the way, of virtual reality. So I point that out to sort of start my comments, and I won't go on forever here, that VR is really a tool that modifies perception. And if we can use it to recalibrate unhealthy perceptions, then VR becomes this potentially radical new tool or therapy to improve quality of life. So I want to show this to you to give you another example of how we're using virtual reality. And hopefully you can hear the music and my voice at the same time. And so this is dolphins swimming in a 3-dimensional space. And this is one of the 360 movies that we often use in the hospital for people who are experiencing pain, anxiety, and so forth. And I saw a patient as a GI doctor who had very severe recurrent pain. I went in and I tried to figure out what was going on. And we had done every test you can imagine, CT scans and endoscopies, colonoscopies, blood tests, everything was normal, but she had this severe pain. So I put her in virtual reality, had her floating around with these dolphins, listening to this music. And within about 4 minutes, she started to cry. And I said, "Are you okay?" And she said, "Yeah, I am, but I think I know why I have this pain." I said, "Really? Tell me more." She said, "It's because of my brother." I said, "Really, your brother?" She said, "Yeah, he died of stomach cancer, and that's how I'm gonna die too." I said, "But you know, we've looked in your stomach. You don't have stomach cancer." She said, "You know, I know that, and you guys keep telling me that, but I haven't been willing to believe it because it's just gonna get there eventually. You just didn't find it this time. But these dolphins, you know, they're telling me I need to move on with life." And she said, "A year on the couch, I wouldn't have figured this out, but something's going on." And I didn't have a functional MRI to see what was going on in her brain, but she said, "My pain is better and I want to go home." Now, it doesn't always work like that. But the question is, you know, what was happening in her brain? And we do know a little bit about this. This is work from Hunter Hoffman demonstrating what happens in the brain with a functional MRI. And what's fascinating, in short, is that not only does it tamp down the physical signals of pain, which are in the sort of sensory cortex, but also the emotional and cognitive aspects of pain here in the middle, in the limbic system, in the insular cortex. And this has been shown clinically when you look at patients undergoing burn dressing changes, women going through labor and delivery at the University of Michigan. In both cases, virtual reality reduces not only the sensory pain, but also the cognitive pain and the affective components of pain. And curiously, people have more fun when they're using VR during a wound dressing. And this is a recent study we reproduced at Cedars Sinai with Melissa Wong, Kim Gregory, looking at this in childbirth using a form of biofeedback enabled Lamaze breathing during labor and delivery. So I want to wrap up and just sort of talk about what we've been doing at Cedars Sinai, because there's a lot of theory, but the reality is our patients are sitting in hospital rooms like this, and all day long, this is all they see. And then somebody like me or Dr. Saxon or someone else shows up, and we're not necessarily smiling and pushing and prodding, and then we disappear and come back again. And all day and night, this is what it's like being in the hospital. So we've been trying to figure out, how can we do better than that? Are there ways to bring our patients beyond the four walls of that hospital to fantastical places? And this is an example, that patient I showed you earlier, reaching out across her visual field as this blue whale visits her in her room. And we've been trying to find out, is this just fun and games, or is there something else going on? We've been talking with our patients, learning from them. What is it like to use this technology? Is the headset too heavy? Are there side effects? Can they tolerate it? Where do they want to go? Some people just want to enjoy going, let's say, on a safari, or they want to go to Hawaii or to an ice cave or something. You know, other people are using it for cognitive behavioral therapy. We're using biosensors, as I showed you earlier. We're bringing people to incredible places that are so diametrically opposed from their current illness experience that it sort of shocks their system in some cases into new realizations. This is visualization from Trip VR, where we use a sort of cyberdelic experience to bring people to sort of different worlds. So I'll wrap up here and just talk about, you know, we've been studying this. This is a randomized controlled trial we did comparing virtual reality versus a two-dimensional TV screen, and found that VR is superior in reducing pain compared to a television screen, especially for patients with severe pain. And we now have 3 active NIH grants that we're studying VR in outpatients for chronic pain, like with lower back pain, where we can use the sort of distraction-based VR as one form of VR compared to sham two-dimensional VR, or actually a full immersive-based VR. This is Beth Darnell from Stanford University, who helped to develop this full 56-module cognitive behavioral therapy program in virtual reality that patients use at home as if they have a pain psychologist with them. So there's so many other topics I could cover today. I'll stop there, but this is a list of many other uses. And so I always say, if VR is a therapy, we need a VR pharmacy, and the FDA now recognizes this. This is an infographic from just before the pandemic, when we all met at FDA for the first medical extended reality public workshop. And that's what the FDA now calls this. It's called MXR, or medical extended reality, We have a website. You can learn more about this stuff if you're interested. And we put on a conference every year. In fact, Daniel spoke in the inaugural version of this conference. And this is the only conference I've ever seen where people are actually literally scalping tickets outside the door. This is a real picture. So there's definitely a lot of interest in this conference and this topic in general. And there's the website if you want to learn more. And Daniel mentioned I wrote a book about this that is really for a lay audience about what is this teaching us about our consciousness and about the overlap between technology, clinical medicine, psychology, philosophy, and through the stories of patients using virtual reality. So since we're here in Hollywood, I'll just end with this quick little scroll to thank all the different people in our laboratory who contribute to this research. And it's a very multidisciplinary team, from computer programmers to social scientists to digital health scientists, epidemiologists, so on and so forth. And thanks so much for the invitation, and I'll stop there. Sorry for going over a couple minutes, but I hope that was a useful overview.
That was terrific. Thanks, Brennan. One quick question, since there's many applications from pain and beyond. Actually, I just recently met a Y Combinator company that has a little headset they'll send you called Flowly with a heart rate variability monitor to do home-based pain times your breaths. But what would be on your wish list for companies like Intel and others to build for next-gen VR, XR, MR that doesn't exist yet or might be needed?
Well, I think HP is setting a good direction with these onboard sensors, rather than having to clip it to your finger, to literally have onboard sensors, but really having some AI and advancing the software to help modify the experience to the individual user's physiology. I think tailoring the experience and making it more sort of bespoke to the individual is where we're going next. So I call this sort of precision immersion. And I think that's a really important direction.
Awesome. So like when you're in the middle of a mindfulness or a pain state, it's watching your heart rate variability, your breathing adjusts as you go.
Yeah, it adjusts the scene that you're experiencing, the pace of it, depending upon where you are. For example, with meditation, I've been talking about meditation today, but my goodness, there's so many other uses that I could just barely even talk about, especially within cognitive behavioral therapy. Lots of ways to personalize that. If we had a few more hours, could talk lots more about opportunities. And
last point before we go to Stefano, because both you and Dr. Saxon are in Hollywood, a lot of the work has been enabled by gaming and other text. What convergent forces do you see next, and who else needs to come into the space to take it to the next?
Yeah, so a big area is audio and spatial audio, which is a big deal in Hollywood. The metaverse is going to be using spatial audio. Sony now has new technology, Real Audio 3D. And we've been working with Jeremy Soule, who innovated that technology and did also, by the way, music for some of the largest selling games of all time, like Skyrim, Harry Potter, Star Wars, the video games. He does the music for our VR and the spatial audio, trying to learn more about how to use that component, because it's not just the visuals, it's the whole experience.
Great, thanks. All right, let's move to Northern California to Dr. Stefano Beanie, another interventionalist turned healthcare technologist and Uber connector and instigator. Also at UCSF as a professor of orthopedics, as you'll hear, founded and shares Digital Orthopedics, which is this convergence of intervention, bones, and sensors and beyond. So over to Dr. Beanie to share some of what he's up to and what's next.
Great, thank you, Dan. Let me see, can you see that screen? Hopefully you do. So, wow, amazing talks. The futuristic perspective of Brennan is phenomenal, and the reminder to remember to integrate the patient's whole self into our data collection strategies that was driven home by Leslie was also really important to keep in mind. So I am a professor of orthopedic surgery at UCSF, University of California, San Francisco, right behind me. Actually, we moved to a different hospital, but that's the mothership. And I do hip and knee replacement surgery, and a lot of it, and also a lot of hip and knee revision surgery. And I'm particularly interested, as you'll see in a little bit, about how to quantify the outcomes. But before we get that, we go there, it's important to keep, I'm going to transition a little bit to Msk Care. By the way, did my slide change? Can you see that? Because I'm wondering. No, I'm having some trouble today. Screen sharing is paused. Why is my screen sharing paused? Let me try this again, because it didn't work in another talk escape. So let me try this one more time.
AI is easy, AV is hard. So it's
yeah, right. So let's try this again. So here we go. So I changed it to the future of virtual Msk Care. Now, why should we care about Msk Care? And on the right is sort of my various titles, but I won't bother you all with that. It's 20% of Medicare spending. I mean, I think people quite realize that as a vertical, it's massive. And arthritis by itself, in terms of U.S. chronic conditions, as John Warner pointed out this morning, it's the number one chronic disease condition in the United States. This is not a small vertical, and it's not a small area to apply our technologies and look for solutions. So within the big context of the big winners in digital health this past 2 years, of course, been telehealth driven, everybody says by COVID-19, but I would argue that actually it was driven by, and one more thing, it was driven by something else, but the uptake was massive. It was 38% higher than it was before, but before it was very low, and we're gone down to about 13 to 17% of all visits now. It's not where it used to be. So people went back to in-person visits. The driver of virtual care, I think, was COVID was part of it, but really was what happened around COVID, which is all these payment equity laws. And in California, these preceded the COVID pandemic, but without them, I don't think we would have gotten very far. So it's very important to keep in mind that all the technology still needs a financial backbone. And that's something that people tend to forget. The other people tend to forget when they sort of whitewash this whole massive explosion of telehealth has been that it wasn't across the board. If you look at some of the specialties, and I think GI is in there in the lower ones, orthopedic surgery, for example, did not have a massive uptick in digital health technology. And we looked at this as a research grant. I am the chair of digital health and social media committee at the American Association of Knee Surgeons, and I was curious about the technology adoption as being an outward evangelist of this technology. So we went to 4 centers geographically disparate across the United States: East Coast, West Coast, Midwest, and the South. 300,000 visits through the pandemic and just passed, and saw what happened. You see, the classic spike that was driven by the inability to see patients was followed by rapid drop-off in utilization. I had entire clinics devoted to digital visits that I had to simply cancel because I couldn't get people to sign up. So why is that? Now, an interesting thing about this paper, though, was worth pointing out. The preference for post-op visits makes sense, right? These are the visits that have the least value, both to the patient and to the clinician. But also no difference in adoption by age group, which is interesting because we have all these assumptions about who's going to use these technologies, and also no difference by geography. I kind of assumed as East Coast, maybe the coast might have a bigger adoption in the South and Midwest, but that didn't turn out to be interesting. So we always have to challenge some of the assumptions we have around the adoption of technology as we move forward. But the question becomes, was it the technology that was the problem, or was it something else? I would argue that it's that we need a UI for the AI. And by that, I mean that interface is not better than coming to see me or Brennan or Leslie. I'm sorry, even with an avatar, it's not quite as good. That's why when people had the opportunity, they went back to driving through traffic to come see their clinicians. There's some element of this that we haven't yet replicated. But we all know we're sort of the believers, right? Let's not judge tomorrow by the technology of today. So I'm going to go a little bit further with this concept and eventually get back to actually a little bit before where Brennan and Leslie are living, more where I'm staying, which is a little more accessible today, perhaps. So where is the technology funding going? At the Digital Orthopedics Conference in San Francisco, which I chair, we have one of our group team members, Nancy Lynch. She is a venture capitalist, MD, who has gone through the trouble of collecting all the funding sources that went into Msk and looked at see how much money is being spent and where it's going every year. We'll be in 2021 at our fall meeting next year, spring meeting next year. But you can see in 2020, we doubled the investments in Msk over 2019 from 340 million to 650 million. And some of these are big mega deals. And all of that, or most of that money, is going to some form of artificial intelligence-based technologies to support everything from scheduling and workflow to imaging to surgical assistance and even preventative care. So when I say the UI for the AI is because all the informatics that are coming our direction are basically driven. They're going to be practical use, are going to be driven by AI algorithms, and we don't have a good way to interpret that technology. So whether it's an app that measures your range of motion through some kind of a camera vision technology, whether the camera is reading an X-ray or a physiological motion of a patient, that information needs to be integrated. Rehabilitation platforms, very popular in orthopedics, but they're having a hard time integrating into the electronic health record and therefore having a hard time integrating into workflows. I'm working with Google looking at sensor-driven data acquisition because I'm very interested actually in going the other way from Leslie, which is we have these patient-reported outcome measures, which are very much patient-centric, but they have massive ceiling effects. And we're doing these incredible interventions, whether they're through using optimization through machine learning, but also just design of implants and technological services, that we can't measure the improvement because the patient-specific data isn't sufficient. So I'm looking to see if is there a way to quantify better. And that's been a lot of Leslie's work in the past. And what we're doing at Google is trying to find new ways of collecting information through sensors that are very specific. And it's actually very cool stuff. But the point is, how can we create a sensor-derived outcome measure, if you will, to help couple the data we're getting from patients about their perception of care? And yet, even if we succeed with that, if all that information is not connected, easily accessible through the electronic health record and connected and to improve our workflows, this is where we're going to have challenges. And what Daniel asked me to ask of Intel and companies like Intel is what do we need to solve? And my answer is this. Is the fact that we're having multiple data streams coming to physicians that need to be collected and presented in a way that we can use them, and then ideally processed before they get to us. So in other words, the sort of common interface standards, now we're all gravitating on FHIR, which is great, but is there something more powerful than that? Obviously, interoperability, the data, the government is driving it. There's a lot of interesting socio-political drivers to interoperability that stand in the way that are not technological. But the concept of a middleware platform or some kind of a healthcare operating system that people have been talking about for about a decade, it's about time that the big companies start looking at making that a reality. It is a financial incentive. There's a financial incentive there. If the people that can actuate that will actually be able to reap a lot of benefits financially. And of course, the metaverse concept, the metaverse infrastructure will also aid that as well as it comes to being. But at DocSF, what I wanted to do at my conference is to showcase people what could happen if we just connected these various apps into an experiential visualization. So it's not as fancy as what Brennan showed and not as cool, but similar to what Leslie's talking about. So I want to share with you. And as you listen to this discussion, hopefully it will work. Daniel will tell me if it doesn't. Just listen for all the technologies that are being called into play to make this experience feasible.
Hello, this is Sol, Dr. Beanie's assistant.
Hello, Sol. This is Tyler. I wanted to ask you about my recent surgery.
Hey, Tyler. I see that you had a total knee replacement 5 days ago with Dr. Beanie. I have access to your records and can help you with any questions you may have.
Thank you, Sol. First, I don't remember what they found at surgery. I was a little out of it.
No worries. I just read your operative report and reviewed the visual records from the operating room. You had exposed bone on both sides of the joint and a torn meniscus. These are both considered excellent indications for surgery, so you can expect very good resolution of your symptoms.
That's great. The live XR was kind of cool. So, I'm glad it was correct. Also, the drone delivery with my medications arrived just as I got home, but I can't remember which pills to take or when. Can you tell me?
Yes. Of course, the discharge summary states that you should take the pain medicine about 20 minutes before you put on your headset for your virtual reality meditation therapy.
And my leg, it's a little swollen as well. Should I be concerned?
First, let's run a thermal scan.
You have my permission.
Thank you. Voice print activation enabled. According to the scan, the skin surface temperature and tensile grade is not suggestive of any complication of a clot in your leg.
Okay, well, that's super helpful, Sol. I feel much better.
Yes, I can see and hear that. Your anxiety measures dropped 7 points.
That's so cool how you can just see that. What else did you find?
You were a little behind on your knee flexion goals compared to other people your age and gender at this time in their recovery. You only achieved 100 degrees of knee flexion and are not putting enough weight on your operated leg.
Well, what do you think I should do about that?
I will send your results to Dr. Beanie's office, as you might benefit from in-person physical therapy. I can arrange an automated insurance approval for the treatment.
Okay, well, that makes sense. You have my permission. In the meantime, what should I do for exercise?
Voice print activation enabled. I sent the referral request and it was approved. We can review the exercises you should be doing, and if you can put on your rehab sensor shoes, I can help verbally guide your exercises.
Well, I like the idea, but can we do it a little later?
Of course, I'll reach out at 7 a.m. tomorrow morning.
You're kidding me, right? I'm supposed to be resting, remember?
Okay, fine. How does 9 o'clock sound?
That's much better.
Great. I scanned your home and see that you have a connected coffee maker. I'll set coffee to brew at 8:45.
Well, thank you.
Right. So now we're dealing with is an empathic interface. I think both Leslie and Brennan talked about that. We have the ability to integrate to the healthcare record. We're ability to track the patient's home situation and integrate into their sensors to, in this case, make coffee, but what else can we do? So this idea of how do we pull it all together? Once you see it, it's easy. So for all of us on this call, for the most part, this is obvious. But I can tell you for most people, when I show them this video, they're like, oh, now I understand what you're working towards, because it's not quite so obvious to so many people.
Oh.
Now, the metaverse. Obviously, that's the next gen, right? You move towards this three-dimensional environment where you've got the ability to do whatever it is you're trying to do, and you got people trying to figure out what to wear, et cetera. And I know this is next gen, but it's not that next gen. Microsoft's already been showing it for some while with spatial. And so the ability to take this concept, it still answers the one question, the UI for the AI. This is simply the next version of it. So what are going to be the drivers of adoption? Obviously, demographics. At some point, the generation like myself that were not digital natives are going to move on and leave space for these kids who will be 20 before you know it, and who will expect a different experience. Fine. That's not news to anybody. The quality of the digital solutions is an important. That's what I try to point out to people by that video, is that don't judge the potential for telehealth based on Zoom conference calling like this. Judge it upon the potential of experience like Brennan and Leslie have shown us, or what I showed you in a minute from with companies like Soul Machines, where the interface is empathic, available 24/7, never in a bad mood, and at some point knows, yes, does know about your diabetes, and yes, knows about your heart attack, and by the way, knows that you have an appointment to go to the vet's office with your dog, and it will remind you at the same time. But this idea of what's going to drive it, at the end of the day, it always comes back to money. It's dollars and cents. In the United States, it will always be that way. And value creation in healthcare is going to transition from what we've done in the past, just to provide in-person services, or metal and plastic in my case, to data-driven digital value creation. That is where the money is going to be. Because why? Not because it's so fancy, but because of the last spot. This is my sort of take on this thing. It's the cost of in-person care. Now, if we go to the next slide, everybody's been talking about the projected health workforce shortages. In 2025, 400,000 home health aide nurses will need, 11,000 physicians. The other numbers you can read on your own. In an economy that's driven by sort of cost is equal to scarcity, the cost of seeing Brennan in person is going to skyrocket. He has X hours a day available to do in-person visits, and to have that access by everybody that needs it is going to simply be too expensive, and we can't scale. We simply can't scale humans fast enough. So there's going to be a desire and need to provide those services in some other way. And at some point, that other way is actually going to be better than what we currently offer in person. And that's when you see the transition of physicians going from being God to being coach, as has been hinted by, I think it was Leslie talking about it. And as I spoke to at Daniel's conference where I last spoke about the future of digital surgery, is this transition. Because why? Because the repetitive tasks, the tasks that can be done through a machine, is going to be transitioned to the machine, and it'll be better than what we can do, until we can only do those things that only we can do, which is going to be empathy, creativity, and even surgery. I'm not so sure about because of the work we're doing in robotics. So we tackle all these conferences. Brennan has this conference. Dan has this conference. I have my conference. It's a digital orthopedics conference, San Francisco. People say, why just orthopedics? Why make it so narrow? I just point out it's not that narrow. There we really focus on change, but MSK is 20% of US healthcare spend. It goes from sports medicine to yoga, all the way to trauma and arthroplasty. Has rich in medical imaging, which is a big area for AI right now. predictive analytics is it's much easier in orthopedics than anywhere else because we have much simpler problems to solve. Telerehabilitation is an obvious application. Sensors and quantified self stuff, perfect for orthopedics. We're all about motion, and all those sensors are about motion. And of course, surgical robotics. So with that, there are people who ride the wave and be successful. Other people will go against the wave and be swept away. So even though the adoption of telehealth, as I mentioned earlier, wasn't so super hot to begin with, I think it's just a matter of time before we see it sort of take over. And then we get to establish the infrastructure upon which we can build the future of orthopedics that Brennan and Leslie showed us so well, and Danielle always talks about. So with that, I'll hopefully leave it at that. I don't have much more to add.
That was fantastic. Thank you so much, Stefano. Maybe a question. I love the UI for the AI, but what about the UI for the, let's say, the orthopedic surgeon? And you've done some work, and Leslie alluded a bit to, the sensors that could go into an implanted hip joint or total knee. Maybe can you touch upon some of those tools to help the surgeon be much more effective in precision that's becoming connected, how you can measure that remotely as well?
Right. I'll tell you, I think it's always great to talk about the potential, and I'm also going to come back and talk a little about the challenges we're facing to make that stuff happen in real time. So the ability to robotics is massively changing the way we think about delivering care. It changes what we can deliver in general surgery. And in orthopedics, the biggest opportunity we're seeing, and we're publishing on it, is the fact that we're decreasing the variability in the outcomes. So robotics, the promise of robotics in orthopedics is to create highly reproducible procedures with decrease in the variation, which is where all the costs come from, because the variation is where you start having problems and complications. So that's a huge opportunity with robotics. In terms of process improvement, we're seeing very good applications of AI in the operating room or our operating suites in general to look at the way we utilize resources and optimize their use of super expensive environments. And so if you can increase output by X%, your ROI is usually a factor of 10 to 20X what the input was to get to that efficiency. We're seeing decent adoption in the tele-rehabilitation space. I think you're going to see massive improvements in that with any technologies coming around. But here's going back a little bit. The challenges we're having at institutions like mine is when you bring in robotics is the cost. And then the in terms of getting the potential benefits back is data sharing. I mean, the hospitals aren't willing to give the robots session files back over to the companies that consider their own property, and so they don't know what to do with it. They're not sure how to exchange it for a fair market value, and they don't feel like it's an option. So that is a silly little thing, but we'll have to get past it, because a lot of the potential benefits that come from sharing the data from these robots across multiple sites, across multiple surgeons. And then another one is fear of the technology supplanting surgeons' work. If my skill set is getting that incredible, if the reason you come to a highly established surgeon or gastroenterologist doing a procedure is because of their skill, they're very reliable. If now you bring a robot into the equation, some of that skill doesn't play out as well. And so the incentives for the people who in theory should be adopting these are kind of reversed, and it's driven more by the consumer. So there's all these little challenges to the adoption which need to be addressed, but at the same time, the potential, as I mentioned earlier, the potential benefit of implementation is going to overcome those challenges, but we do have to overcome them.
Thanks. Well, we're now in the real jam session. We've got 25 minutes left. Anybody want to jump in with a question, comment, idea, or synergy? Don't be shy.
Yeah, I will. I was really fascinated by Leslie's talk, and I've been working on this concept as well about normative data. I think it's a very interesting question mark, because we have, I think in medicine, we have datapenia. We're generating more than anybody else, but we actually don't know how to use it, and we don't have access to it. So Leslie, how are we going to get to normative data sets? We have lots of EKGs. So you get a new EKG, you know what it means, but you're getting reams of data from patients, but you have no idea what it means and how to normalize it. How are we going to get there?
Yeah, it's really interesting. Like about 5 years ago, I collected EKG during one of our Trojan football games, okay, into EKG on both sides of the ball for a whole game. Every contact, and there are a lot of different skilled positions in football. And so there is this enriched risk of sudden cardiac death, for instance, in certain sports like football or basketball. So I'm still sitting on that data and looking at it, as well as a lot of other athletic data. When we started collecting left atrial pressure daily and constantly in patients with heart failure, when we did a clinical trial, I was seeing these left atrial pressures of 2, and then they'd go to 20 after a patient ate a pizza, maybe got ischemic, got some mitral regurgitation, then they go back to 4. So which one do you treat? And do you treat the 40? So I was, I remember I had a nun who did really well with the sensor, progressed to a heart transplant later, but I drove her left atrial pressure down so low. She said, Dr. Saxon, every time you drive my left atrial pressure to 2, because patients were able to see their left atrial pressures, I get up from praying and I faint. So I've decided to cut back on my beta blocker, my diuretic. And at 4, I'm like dialed in and I can pray. And I was like, oh, that's so humbling. I actually caused her to have syncope a couple of times because I thought I was optimizing her on guideline. So what I find encouraging and what will accelerate this is that, first of all, these high fidelity measures are very individualistic. And so what is a good left atrial pressure for one person, as long as they're under 11 and you keep them, in control, it's very individualistic. So people learn their best left atrial pressure where they can stand, but it's still low enough. And when they can cheat and eat Chinese food, because a lot of chronic disease non-adherence, as you know, is due to this inability. It's hard to be on a diet constantly. So I find that the normals vary for each patient. I think this is incredibly true in nutrition. A lot of our nutrition, using ketone sensors or other things and studying nutrition in warfighters, there's a big difference, just like there is in susceptibility to brain injury from blasts. There's a huge difference in how you respond, what your glucose ketones look like, depending on your diet, depending on who you are, right? So you have to almost learn with the patient, every patient's kind of gut health, brain health, heart pressures, and those are creating all this new normative data. But you can still make a lot of progress on the individual level with the patient. So we do this work, we're doing this work now. And, again, sitting on all these constant analyte measures of people during different training scenarios, different diet, and suddenly getting all these insights, because we're so ignorant about some very basic things with human health, right? Where's the nutrition science? It doesn't exist, basically. A lot of the stuff, is just our big gaps. So the other thing I just wanted to comment on as it relates to VR, because we spend a lot of time there, and I'm interested in this from Brennan, because obviously it has a lot of applicability. It also has a lot of potential risk associated with it. So, VR has been used for exposure therapy. Soldiers, USC has done a lot of this work. Soldiers returning with PTSD, you put them in VR, you slowly reintroduce the traumatic experience, and you hopefully help mitigate their PTSD. But where Brennan's talking about VR is restorative VR. How can it be used to restore a person or to reset a brain that's been otherwise rocked for some reason, emotionally or from blast or something else? How do you do the ketamine or whatever that effect is, the psilocybin effect within a VR experience to reset folks? What's the dose of that? How do you use VR safely in children? Potentially really bad. You could torture people pretty bad in VR, worse than you could torture them basically any other way. So I'm very interested, in what is the dose? What is the type of VR? How do we categorize it? How we start to test its safety, particularly in younger populations? Maybe that even means people prior to age 22, when your brain is, I have no idea. But I think these are really promising. But again, I advocate for the research in these areas, because otherwise it's not going to be, I think it could be potentially pretty bad.
Maybe I'll address that, and I was prepared to address the normative question as well, so I'll try to keep my comments brief. But certainly the FDA cares very much about the questions that you've just raised, as do all of us that are in the research environment around VR. A couple years ago, we published a set of guidelines to address the safe development and validation of VR therapeutics. And so we published this international consensus, which included Skip Rizzo from USC, whose research you're describing here regarding virtual exposure therapy. So he was a member of this 22-person international panel. And we laid out a framework, just like FDA has three initial phases, FDA 1, 2, and 3. We came up with the specific details of VR1, VR2, and VR3 trials. And I won't go into the details here, other than it's essentially a checklist of best practices that developers really need to matriculate through before they get to the point that we have something that's safe and effective. And just like any other digital therapeutic or any other pharmacotherapy, we need to have guardrails around the development of these programs. And we follow our own VR1 through 3 pretty closely. In fact, we just submitted for peer review a VR1 trial for a brand new cognitive behavioral therapy for irritable bowel syndrome. And that sort of wraps around the earlier point about exposure therapy, which we do a lot of, I just didn't talk about today. But for example, people with IBS have trigger environments that really make them upset, stress them out, cause abdominal pain, diarrhea. Imagine, for example, you're in a bathroom, a public restroom, you have IBS, you're late for an appointment, you can't get off the toilet, there's people waiting for you to get out of the stall, it's loud, it's annoying, and all that's happening. You can either imagine that, or we can literally put you in there, which is exactly what we do. We put people in a public restroom. We have the sounds going. We have people's feet outside shuffling. And then the bathroom stall becomes a CBT grid where you start to work through exactly what are you feeling, what's happening, what thoughts are you experiencing, how do you restructure those thoughts? And then we can use biometrics to determine how much cognitive load is this taking. And over time, can we demonstrate that the patients can more quickly adapt to stressful environments physiologically and psychometrically? But all that takes a lot of effort, time, research. It's not like you could just pop these things out and throw them out there. So that's a long answer, I guess, to that regulatory question. And then I'll just quickly add in terms of normative, I see, so Dave Albert and I, along with Noel Barry Mers, are sitting on thousands and thousands and thousands of data points right now with a live core, and still trying to figure out what to do with it. Because what it comes down to allow that avatar that we saw to actually come to life is we need predictive analytics, and that is essentially normative data. How can we predict whether the tensile whatever that metric was, the tissue tensile strength and the heat is really predictive of a PE or a DVT? That's where we need to be going. I don't think we need better and better and better sensors or smaller and smaller and smaller sensors. I think we need to start figuring out how do we actually use these data to predict clinically meaningful endpoints. I know that's been going on, but I don't think enough. We've been trying to understand how do these data correlate with PROs or patient-reported outcomes. Can we really predict somebody's level of anxiety, depression, et cetera, using Fitbit? It's one thing to say that, it's quite another to actually demonstrate that. So I think there's a lot of fast and loose claims, and I think folks like Leslie, others have been working for years trying to get to the bottom of this, and it's really tough sledding. And that's, to me, where the hard work still remains and needs to continue.
Yeah, Dan, it's such a rabbit hole, because you think, like, we've been working a lot in just early brain injury. It's been a big problem with the 20-year war and all the blast exposures people have had. There's this huge category of mild TBI that nobody really knows what it is, but there are a bunch of behavioral manifestations and cognitive and other changes. So you'll take a blast, you'll look at a person exposure to that blast based on their chronic exposure to blast. It's not just the blast, it's the fact that they were in an environment in the desert with a lot of particulate matter, exposed to high heats and helicopters and burn pits and wherever they grew up. And one person's ocular reflexes to a blast when they're back in a training environment is very different. It depends on how well they're integrating, how hypervigilant they were in their last deployment. It's like all of these factors, they're highly individual. So these normative values can turn out to be very individual. And that's another just piece of this as you start to look at these earlier and earlier markers in that case of brain health. So we obviously don't want to repeat this in our next conflict, the kind of brain injury we've had with this 20-year war, right? So just trying to kind of look at how to study that early susceptibility and then measure it, learn its time to recovery, because we'll see these deviations, right? And then, okay, well, that's an insult, but what's the time to recovery? Is it acute or chronic? That's why we have these new neuroproteins that are released. We can measure for concussion. Maybe we need to validate them for blast. Do they go up and down? When can you re-expose that person? So many fascinating issues that come up as you start to see this data and think about it. I think it's going to take so many people, but to ultimately figure it out. But it does provide immediate insights into vulnerabilities and stuff, very early vulnerabilities. I'm sure you're seeing that. Brennan, I'm sure you're seeing the therapeutic effect without really even understanding it. You're seeing people get better without knowing the why, right? Not having functional MRIs on everybody. It's just, which is great. I'm not saying you need to know the why, but there's just a lot here.
There's a plug for musculoskeletal. It's so much simpler than the topics you guys are dealing with. I mean, traumatic brain injury, inflammatory bowel disease is such a huge psychological component to it that we barely understand. With us, a bone's broken, bone's broken. If your ACL is broken, ACL is broken. If you can bend your knee, you can bend your knee. And if you improve your bending of the knee, it's a super simple metric. And it allows us to start asking those questions and testing them in a much, much simpler place with fewer variables. Not to say that those variables don't come into play, but as how much they impact the outcome, it's just a simpler environment.
Yeah, actually, I wanted to pick up on, Leslie, you had mentioned something earlier, and let me see if I can go back, where you were talking about, you wonder who these big companies, why they haven't jumped in, why they're not doing this, or we're counting on health systems. And I think that counting on the health systems, they're already so busy with high levels of complexity that oftentimes they don't have the ability to do this. And most of this work that I'm seeing done, it's being done in medical schools, and it's not included in pharmacy or nursing schools where you've got a lot more community. So if we were thinking about having a lot more people using this, getting a lot more data could help to normalize it, but also seeing people in native environments and pick things up on a much earlier level. This use of the data to do surveillance for, who is at risk at diabetes? When do we need to intervene? What are we doing about vision? What are we doing about mobility? And so working with a much broader set of clinicians who are seeing people, not patients, but seeing people in lifestyle environments, so that the whole use of data and digital and wearables and looking at that for surveillance and picking up things at a much earlier stage, I think would be as helpful to managing the severe and the chronic and the more unusual, or the more complex. So I see a lot of this in the medical schools, but I don't see it. I mean, particularly Parisa, you can speak to this, how much more we would use this in pharmacy to be able to help people manage medications and their responses to it, patient-reported outcomes, mental health, school systems, with kids. So, particularly in the athletics. So I'm just, when you said, who's going to adopt it? How do we get our data being used, normalized, bigger data sets, more people? So just thoughts about that.
Yeah, and I'll just say, oh, go ahead, Dr. Albert.
Well, I'm just going to, Stefano, I had knee surgery as a D1 wrestler in March of 1974 by a guy named Arthur Boland at then Peterbent Brigham Hospital. Leslie knows my wife is a rheumatology faculty member at USC. She says I'm the only person she knows who had knee surgery, wrestled 3 more years, went the Olympic trials, and still have my own knee. Why is my knee better after all of that than the variability in outcomes in your subspecialty, critically important, and one that I think you've talked about, can robotics improve it? I think that's where we need monitoring. Somebody needed to monitor me and wonder, why do I still have my knee? Why can I still walk without pain? Because my wife deals with the pain every day, and she says, you're a freak. Well,
right.
Why am I a freak?
No, you're not a freak. I'll answer that question. I have 2 buckets of patients. Patients who come to see me because they have lost their functionality, but have very little pain. I know people who have massive amounts of pain, but frankly, the knees are working pretty well, or shoulders or joints, whatever it is. So there's two buckets of people, and it has to do with the way we're wired. And I think Leslie probably has had that experience as well, dealing with athletes. And some people, particularly athletes, seem to have a higher threshold for pain. And people understand that humans are threshold driven. This is something else you don't have much pain until you do. It's more like a tire. You don't notice you're running out of rubber until it pops. And you're like, what happened? It happened all of a sudden. It didn't happen all of a sudden. You've been getting there very slowly, very closely, and then it goes over. But some people's threshold for that is higher. So they can drive around with the car without tires for a while and just make it work. And others like, man, I gotta get a new tire. So it's so that is I'm sure there's genetic underpinnings to that, but there's also behavioral. I can tell if you're one of those patients by your tracings from the way you walk, and then correlate them with the X-rays. So we can infer that even if we don't actually know the genetics of it. So there's an opportunity in data where a lot of people are going now is phenotyping. So this idea of using machine learning algorithms to create phenotypes of clusters of patients that will behave a certain way. And once you've clustered people, then you can get closer to precision medicine without necessarily getting to the individualized precision medicine that we were talking about earlier.
Thank you.
Very welcome.
Appreciate you. Want to comment?
There's a question about the data. Do you want me to answer that?
Let's go to Risa for a second, and then we'll switch back to also how do we unleash some of this data. There's a question earlier about robotic surgery platforms not shared back to the robotic companies, but Risa, and then let's talk about how do we unlock some of this data so we can get that those insights in a more holistic way. Risa.
Thanks, Daniel. I was just going to thank Shauna for mentioning pharmacists and pharmacy. I was a little late to this call because I was presenting to the University of Minnesota to their students and faculty about all the things, all the changes. And actually, Dr. Spiegel, you'd be glad to know I brought up VR. And I was really trying to provide to what's possible, and really we had digital
Lisa, we're losing your signal. Okay. Internets are not completing sentences today. Let's pivot to the question about, while Risa hopefully gets better signal, to the question of unleashing some of the data that's often siloed. So there's a question from Intel earlier for Stefano. Some of the data coming from a robot in your OR isn't flowing back to the manufacturers still and improve. And that there's data silos everywhere. Anyone wants to comment, starting with you, on the data silos and how to unleash the possibilities of putting them together?
Yeah, I think I think companies that have these want the data. So the hospitals that bought the machine that for millions of dollars sometimes that's generating the data, and the data is being generated by clicks that are being intuited by their staff, their surgeons, their faculty. They consider that IP. And the sequence of clicks, et cetera, is the IP that they would then be giving back to the company, and they want to be fairly compensated for it. They expect these companies to go out and make tons and tons of money based on the algorithm they develop on that data, and they want to have some revenue back from it. That's really the mindset, as far as I can tell. If you really want to drill down to it, they then talked about security and privacy, but at the end of the day, security and privacy can be addressed. So there are going to have to be some collaborative models, financial models considered, and I've heard some really cool and interesting ones that I can share with you, which is one is the idea of leveraging the blockchain. So that if you put data of any kind onto the blockchain and then that data is accessed, you simply get paid for when the data is accessed, and that data become more valuable the more that the data you input into the system. Because obviously, if somebody gives me their data today, that has a certain value, but if I've got data for that surgeon or that machine over a prolonged period of time, then the change in the way that data is collected gives you some insight into how to improve it, and that is more value than if you just give it occasional instances. So there will be interesting new ways of doing that.
We've got 5 minutes left. Anyone jump in?
Can I jump
questions,
in?
Short answers.
Yeah, just a quick one. Dr. Bini, you just mentioned that is there no, and this might be very naive of me to ask, but is there no way to have, like, for example, Apple has like iOS updates to a certain extent. So I almost wonder, like, sharing this data back, can it not create like software upgrades for a lot of these robots such that, you know, it's mutually beneficial for both the company to have a better product, but then you also to have an updated software that, you know, obviously the hardware still stays the same, but maybe you get a better overall ability to operate.
That is exactly the argument that companies make back to the purchasers of their products, right? So we're going to give you a better experience. And yeah, but you're giving that better experience to a bunch of other medical centers, and that makes your product more valuable. So we want to have part of that.
A great question from Shashi. I'll point to Leslie and Brennan. What are some of the questions in the tech that the tech industry should be asking but aren't? Any kind of burning examples there that you have?
Nobody really understands cloud storage and security. Everybody buys these expensive products that it's supposed to have. Nobody really understands it. I mean, I think to Stefano's point about, you know, really being able to articulate the sort of platform and storage that all this medical data, the policies around it, legislative, nobody. So for a tech company who can, I mean, even we buy secure storage and other products from Amazon and Microsoft. And I don't even think at some point hiring security consultants that they understand their products. I honestly don't think they do. So I think a company that can articulate their product offering in some of these spaces very well is going to really have a market advantage.
Awesome. Brennan, any questions?
No, I think we're looking at the time. I'll stop there. Thank you. Let you wrap up.
Do you know, you have a quick answer to that question? What's not being asked or what would be on your wish list?
I think I sort of, the thing that pops into my head I've already addressed, which is we need to do more work on AI, more work on predictive analytics, and figuring out how to truly integrate them within the EHR, that terrible software program Leslie described earlier, to make it less of a billing and administrative tool and more of a tool to support, you know, true digital health and remote patient monitoring. You know, we talk a big game all the time. We like the digital health community, but I go into my own clinic every week and I'm not doing almost any of this. I do use VR actually in my clinic, but that's about it. So there's still a lot of work to be done with the infrastructure and the technology to make this happen.
100%. We're still in the early stages of much of this in terms of the potential to connect all the dots. Anyone else with last questions or comments?
Daniel, so if I had to give one last one, it would be to ask companies like Intel, like Microsoft, like Meta to invest more in articulating the vision of the future. I think that there is I think most people can't really put it all together the way the folks on this call are putting it together in their own heads. They just don't have access to information. They're plenty bright. They just don't have it all put together. And participating with those, supporting those of us that are trying to do this, to create that visual, that experience, and understand, okay, this is where we're going. It's a future worth building, because otherwise everybody is going to get caught up with their day-to-day challenges, whether it's ROI for their clinic for that particular moment or seeing another patient. Why would I do that? It's articulating the reason why we should move forward, articulating the reason for change is something that I think needs to be done more.
So with that, I'm going to hand it back over to our friends at Intel, Stacy or Maria. Any closing thoughts or comments as we finish our amazing 90 minutes? Well, with the topic.
I'll
jump in, Maria.
Okay. Again, you know, and every time we've done these jams, just amazing conversation. And again, for those of you that are leading our discussion today, those of you that are familiar faces or new for the first time, we're really pleased, and we're listening and trying to crunch as much information as we can and turn things back to the group so that there's this value exchange with all of you. So thank you for your patience, for those that have started this journey with us and trying to get that information back out. We, as stated, hopefully this has been a great conversation where many of you can continue to connect, continue to have conversation. Today's string, I think there were a lot of connections made, and we look forward to that continued dialogue. We will be hosting another jam and trying to send out that information as fast as possible into December, and then also looking out into 2022, which is amazing to say. Daniel, as always, We really appreciate your collaboration here and leading us through these conversations. So thank you.
Great. Thanks, Maria. Thanks, Stacy. Thanks to the Intel team. And thanks for everybody, especially our lead discussants, Leslie, Brennan, and Stefano, for really bringing some amazing experience, insights, and continuing to collaborate and converge all these technologies to bring us a better future of health and medicine for all. So thanks. Be safe out there. Keep innovating. And we'll see you on our next jam. Bye.